Thank you for hitting play, and welcome to the series we're calling Data Pioneers. We're bringing together the brightest minds in the healthcare industry, supporting the transition to value-based care. We'll be highlighting the best practices, tools, lessons, and advice with a focus on data and analytics. I'm your host, Rich Waller from Wellstack, and we're very excited to have you join us today. On today's episode, we're joined by Dr. Robert Jarve, the Associate CMIO of Population Health, and Kristyn Vermeesch, Value-Based Programs Financial Advisor, both from Corewell Health. This is an amazing dialogue where we get into the details on paths for early wins in starting value-based programs and some great advice and learnings no matter where you are in your journey to adopting risk-based contracts. We also touch on upcoming innovations, local and national implications on staffing shortages, impacts of pharmacy and other specialties, and the day-to-day details of running value-based care programs. We really hope you enjoy it. I really had a great time. So let's get started. All right, welcome to Data Pioneers. We are joined today by Dr. Robert Jarve and Kristyn Vermeesch. Dr. Jarve, Kristyn, I could not be more excited about our time together today. Thank you so much for joining us.
Thank you for having us.
Yeah, this is going to be great. So before we jump in, by way of background, it would be super helpful if you both could give us a quick intro on you and your role and maybe some of your experience in the healthcare industry.
You go first, Kristyn.
All right, so my name is Kristyn Vermeesch, and my role in the organization is to oversee our financial performance for value-based programs. So that includes risk, quality, pay for performance, the whole gambit. As part of my experience, I've been on both sides of the world, both delivery, plan, and government. So it's really exciting, and again, thank you for having me.
I am Bob Jarve. I'm a primary care physician by background. I've been in practice for over 20 years now. The first 10 years of my practice was pretty much just a full-time primary care physician, seeing patients, got involved in a lot of value-based programs towards the end of that 10 years is related to the primary care medical home, and there were some different CMS programs that came out, and really started getting into data and analytics after that. I've been a medical director of population health analytics for several years, and now I'm the associate chief medical information officer for population health for Corewell Health, and really lead the strategy and development of our population health analytics platforms within Corewell Health so that we can manage our risk contracts.
Thank you both for that. That's really great. So as we're diving in, what along this journey would you say has been most surprising to each of you? Maybe Dr. Jarve, you can lead us off.
When I first started this journey with just going into value, I'm going to back up even further. When I first went into practice, I thought I was going to be going to primary care, doing what we do in value. And then I realized that fee-for-service is very siloed and very widget-oriented, and that you don't really, it's not integrated and connected. And when I first saw value coming on, I'm like, oh, we've got a solution. And I thought that it would be pretty straightforward going into value to get to the place I thought I wanted to be doing when I first went into practice. What surprised me was just how hard it is to measure that you're improving outcomes in a value risk contract when you're trying to see with these different models that you're putting in, if they've improved compared to the baseline, because you have to have these benchmark populations and they don't usually exist easily, and you have to risk weight them. And so that was really kind of a shocker for me, just the complexity of it.
Yeah, I think the same thing, as well as just to the underlying foundational understanding of what is value. I mean, we talk about it kind of like we talked about accountability and transparency, but what does value mean, and who does it mean value to? And so I think breaking down that piece and having that literacy is probably the one crux of the foundation. Then you can layer on the analytics. So that's kind of been that one aha moment.
That's great. And, Dr. Jarve, we had a conversation, maybe a few weeks ago, and, you had laid out, I thought, very well, sort of some of the the progression of, of moving to value-based care, kind of starting with, some of the low-hanging fruit on utilization management, and then moving into, full population health management around, specific risk profiles. And so maybe if you could walk us through sort of how you see that progression, and then maybe even into some of the innovations that you see coming that, are exciting.
Yeah. So for us, when we started going into value, if you really try to do population health management, which I think is the holy grail for a value-based contracting, that has a return on investment window of at best 2 years, and usually it's a 3 to 5 year window you're looking at. So you have to get started pretty early on it, but you can't actually show return very quickly. So you have to have other strategies that you're deploying right away. And there's two key strategies that are the low hanging fruit. One is, if you're in an ACO or if you're in a Medicare Advantage risk contract, really focusing on disease burden, make sure you're understand what are all the different conditions that are high risk, and that you have a plan in place for them. And that you've actually documented that you're managing those conditions. The second one is start looking at utilization management and understanding where is your low-hanging fruit for, maybe it's pharmacy, and looking at your similar bioequivalent medications, and finding where there's opportunity to lower costs by using less expensive, equally effective medications. Looking at different specialties and looking if they're overutilizing certain high-tech radiology. Those things can get us a return on investment in the next 1 to 2 years, and they help sustain you as you're going. But there's a cap on how much you're going to actually be able to get out of those programs, without actually cutting into quality of care if you really start to do hard. And then you have to get the ability to get your data in place so you can understand who is your whole population, track them in a regular time increment over time, and start understanding what are the drivers driving actual poor health outcomes that you can put different programs around that will mitigate the risk and decrease them from going into poor outcomes. And that's really the approach we've taken to try to address the issue.
I think
That's
just
great.
piggybacking, sorry, go ahead.
No,
Piggybacking
please.
off of that you start with understanding who your whole population is. And I would argue that needs to happen even in a managed care traditional space. Because as we think about our holistic financials, whether you're a plan, you're a delivery system, you need to understand where your revenue is coming in and where are your risks. And understanding those spaces and places and how they intersect is so critical. And that, I would say, is your baseline data, which is where Bob was or Dr. Jarve was kind of alluding to. So as we kind of work through that space, and the next is how do we stratify by risk and understanding? So we may have an opportunity in some places, but then what is the interventions that we need, and how does that match with that return so we can effectively provide those interventions?
And have you found any tips or tools or kind of things that you can share? A lot of that is fantastic, but quite complicated, right?
Yeah.
So, go ahead.
So we talked about this in the conversation before. One of the challenges that we've really run into is when we first implemented our EHRs. For us, if you look at the rest of the industries and other industries, they've been using data and analytics for decades now, in some way or form. Before 2008, I had paper charts in my office there, and I used a DOS scheduling program. There was no data. And really 2008 was a tipping point, because there was the HITECH Act that really gave incentives for our healthcare organizations to implement EHRs and penalties if they didn't do it within a certain time frame. So we implemented all these electronic health records, which should have theoretically given us a ton of data. But the goal when we were implementing those was really optimization and efficiency, and not go bankrupt, because there's such low margins in healthcare. They couldn't afford the productivity to drop on any of their service lines when they implemented the program. It's only been recently, since you've seen MACRA and some other things get passed in the government, that you start to see the focus turn towards data and really understanding data. Problem is, in EHRs, we've designed all that data to be siloed into a service line. So if you look at labs, it's designed to understand how many labs were done and what type of lab, not to understand how a patient traversed over time and what labs they had. And so we've had to spend a lot of time building out registries and a population health data model, connecting all these different data sources into a longitudinal person-centric data model with a consistent unit measure of time so that we can actually slice and dice that population and understand trends. And I think that's the trick. And you have to be very careful how you do it. You can't, we've tried build it and they will come approaches and have been sorely disappointed in the approach. So our approach has always been, what are our use cases? And every time we build something, let's make sure we're building it out the metrics in that model. And that way we can rinse and repeat them for other use cases as time goes on.
That's fantastic. I think, a lot of great learnings there. And certainly probably, I'm sure, a few battle scars along the way, because, it's certainly been a journey. So let's talk about a little bit, maybe some of the dynamics within the pharmacy landscape. Kristyn, maybe we can start with you on that. What are you seeing as challenging? What are you seeing as kind of interesting, in that area?
Yeah, so pharmacy spend has been increasing, right? And between 21 and 22, that spend increased by 9%, more than most any other space. And we're now at this opportunity when we look across the various markets, whether you're talking commercial or government contracts, pharmacy is surpassing any other place's spend, including inpatient. So dissecting what's driving that pharmacy spend and then understanding, is that appropriate and where is the opportunity is kind of that, place of where we're really working and striving to be. Part of the challenges are the rebates and discounts. I think, price transparency is a huge challenge to get through, to understand. Just because we might see it cost $55, maybe after rebates, it's only 10. So is that 10 variation appropriate? And this is where some of the work that Dr. Jarve has been leading with our population health data model is really going to be helpful when we can start to look at the observed versus expected, because where we see spend go up in $1 PMPM, that might be okay because the trends across the system are going up. You can't look at pharmacy in a vacuum. Like the new hot topic of GLP-1s, it's kind of surpassing or supplementing the bariatric surgeries. So we have to understand for what populations do each intervention is most appropriate, and then how do we apply that? And then how do we work with our pricing partners and our risk contracts to make sure that those fluctuations in the market are reflected in whatever agreements that we may enter into?
And I'll follow up on that. The GLP-1s is a great example because, GLP-1s are an amazing medication. And I would love to give those medications to a lot of my patients. But when you start to look at the cost of those medications, it's as much, 1 year of those medications is as much as a bariatric surgery. And bariatric surgery is a 1 year cost and then it's done. Whereas these are that same price. It's like getting a bariatric surgery year in and year out over time. When we look at the pricing, health insurance, at least nonprofits, usually are looking at a 2 to 3% ROI, and that's just to go back and cover inflation and invest back into the populations. They're not making a huge, margin on when they're doing these things. And when you add a drug like that literally increases the cost per patient of that condition by $8,000 to $10,000 a year compared to what it previously was, that has to get factored in somehow. And where it gets factored in is in premiums. And so if, when patients see that, they're seeing a copay that's maybe $20 or $50. They're not seeing the full cost of that medication, and they can get very frustrated that you're not allowing, you're not giving everybody the access to it. But they're not seeing that if we did that, how much we would have to increase the premiums to cover those costs. And meanwhile, this is my personal bias, but you have most pharmaceutical companies, instead of a 2 to 3% margin, they're looking at a 20 to 30% margin. And when we look at the cost differential between that GLP-1 between us and Canada, you're looking at $1,000 a month in the US versus $250 in Canada. And and that's true for all of Europe. And you look at one of the main GLP-1 companies, they're not even an American company. They're based out of Europe, but they're still charging us $1,000 a month and everybody else $250. There's an issue there that we have to address, because that where we struggle in value is the pharmacy costs just keep going up and are really making it a challenge for us to figure out ways to actually provide high quality, valuable care for our patients and improve outcomes.
Well, and that's where the conversations come back to the payers, right? And sharing the knowledge and experience that we're co-learning together in these developments of new technology. Again, we'll keep picking on GLP-1s, but it's any new technology that as it comes into market, what are the cost effectiveness of it? And I know that that's not a word that we often like to use in healthcare, but it is very much an economic principle that we apply, right? And so as we look to understand a lot of the costs for obesity and diabetes, which these drugs treat, is not just in year one. You're looking at mitigating disease progression over a lifetime at those costs. The challenge is how do you create a snapshot of a lifetime of costs into 1 year of pricing? And I think that's that rub that we're constantly in. So how do we, each learn together in those spaces and places, so that way we're accounting for those savings and reflected in our premiums. And yes, you're right that the price of the cost of the drug and the out-of-pocket cost that can sometimes create a disconnect in the actual cost. However, where it gets felt is in the premiums. And so you see patients making very different selections when it comes time to select for their benefits, because we're all trying to manage within our budget constraints. And it's not just a competition of one provider versus another system or one health plan versus another. It's a competition between other commodities such as food, gas, electrical, and all those basic staples. So that's where it's so imperative, all this analytics and having, just like, we kind of talked about, having it in a usable format so we can make meaningful insights, so we can kind of figure out how do we coexist together as pharmacy, delivery system, and plan to try to make healthcare more affordable for the patients that we serve.
That's great. And you mentioned, in that description, the kind of the importance of social determinants and, kind of bringing that all together. In terms of a big part of this series is about data's role and the role of data and analytics in this. With the kind of multi-dimensional problem we're dealing with, from, like you just mentioned, at least 4 or 5 different divisions or groups, that have to come together. Have you seen it? What's exciting to you about, how data can bring those teams together to, kind of develop a strategy that addresses all of those different angles? Are there technologies or innovations you see coming, those that are here? Maybe we could talk a little bit about that.
So for me, I think data opens up the platform for a universal conversation. It's like that picnic blanket that invites you to come sit down and have a chat. And it pulls in all of those different components, whether you're talking plan, delivery side. And delivery side just isn't isolated to one silo. You've got to pull in your specialists, your PCPs. We have a whole department here, and like many do, about social determinants of health. And so how do we pull in all of those spaces and those resources to understand the underlying population's needs, their barriers, and then what can we realistically do? And that's, again, where data is a nice intersection, especially when you can slice it and dice it in a couple different ways. So you're not just looking at cost trends, but utilization trends. You pull those insights about what counties, what specifically in those counties are we seeing those barrier gaps. And so I think that that's where you have an opportunity for super exciting innovation. And then to, the point was we talked about metrics. When you're having those conversations, you can build those metrics in up front. So then it becomes easier, not easy, but easier to measure what impact are we making for those targeted populations and how and why, and what can we rinse and recycle and repeat.
I would add to that, there's 2 things we're using SDOH data for right now in 2 different ways within our population health work. And then there's another way that we're moving with when you ask what's the technology that's coming that we're interested in. So we use SDOH factors. We have a high risk underserved clinic that really manages these very high risk, high SDOH substance use and mental health, as well as medical complexity. For our value clinics in general, we have the ability to risk weight the panels by morbidity. When we looked at that clinic, we really had a difficulty in weighting the panels by just morbidity, because it underweighted the complexity of what they were seeing, because it didn't take into consideration the SDOH burden that these patients had. So we were able to use SDOH data, geocoding, and socioeconomic, CMS socioeconomic variability to develop a way to risk weight on SDOH for those providers' panels within that high-risk group, so that we could give them credit for the complexity the SDOH brought to those patient panels, and not have expectations for a panel size that, quite frankly, would burn out our providers, and had historically caused burnout for those providers. We also, on the flip side of that, we have a population health management dashboard that we've put forward, and we can look at area deprivation index, socioeconomic index on populations, but we can also drill down to the specific domains that we're asking patients on, such as social isolation. And one of the areas we found this to be helpful is, if we're the west side of our of Corewell Health encompasses a good chunk of the west side of the state of Michigan. So there's Grand Rapids, which is a fairly metro area, but if you go outside of Grand Rapids, it becomes rural very quickly, rural and agrarian. And when we look at COPD as a condition, we find that it's much more prevalent in our rural areas than it is in our urban areas. When we look at the outcomes of COPD, and when we look at that condition compared to others, we see that they have much higher social isolation. And so we're starting to figure out that we need to address that condition and mitigate it, and come up with strategies to address it, because it's driving a lot of our poor outcomes with COPD and with ED utilization and other things. And that's where you're starting to get to actual plans based on the data, because you're connecting that SDOH data to specific populations, specific providers or practices, but also specific conditions. And then you're able to slice it by what are the outcomes that they're having within those conditions for ED per 1,000 or inpatient per 1,000, and do they have worse or better outcomes based on different factors. So I see us going there. What I will say is that when we look at our SDOH collection of domains, it's going to improve quite a bit with CMS now requiring all inpatient admissions be screened for certain domains of SDOH starting in 24. But it's a small percentage of the total that we collect. It's hard to collect those domains. We're looking at natural language processing and pulling out those domains with natural language processing, and using that to help us understand at a population level what is the likely burden of a given social determinant, but also to help us identify patients where maybe we should focus even heavier screening operations on, because we know based on the notes, it's been mentioned that they have a potential for that social determinant of health. And we've looked at homelessness in particular on that, and we're seeing some promising early results when we're looking at that area.
And I think that's the exciting part, is collecting the data is important, but then you can start to think about, okay, how do we partner with our communities? And every partnership is going to look a little bit differently, because screening is one thing, but we also need to understand, okay, then what, right? It's like that diagnosis of I have the flu. Okay, sometimes doing nothing and waiting is fine, but other times you have to kind of intervene, and what does that intervention look like? So I think that's the kind of next layer that becomes really exciting. First, you have to understand what you're kind of facing, and then you can start to link it with interventions across the communities.
That's fascinating. It's really great. One of the big topics in the industry right now, across the board in healthcare, is staffing, and specifically staffing shortages. I'd love to get some thoughts on how that's affecting this transition to value-based care and some of the dimensions there.
So that is one of my greatest concerns and fears, quite frankly, is the shortage of PCPs. So in the state of Michigan, we have 83 counties, and 58 of those counties are rural. All of those 58 counties are in a rural, underserved physician shortage space. So we're already in that. And a recent study came out and said we would need to add over 800 physicians to maintain our already ridiculously high physician to patient ratios. So what that tells me right there is that, one, who's going to care for the patients? And we can think about different innovative technologies. Urgent care helps certain things, video, but that doesn't resolve the shortage. You also need a PCP for risk contract, because every contract is anchored to a PCP attribution. So what happens when you have no docs? So that's probably my biggest pain point that I see kind of coming through the horizon. I don't have a solution because it's bigger than our system, but I do think that that's probably our greatest risk.
There's two places that I see us really struggling with staffing. One is exactly what Kristyn was talking about with his PCPs. I've been in practice for 20 years, and for the first 15 of it, it was like the kid crying wolf, because we would show these graphs showing we were going to have a PCP shortage, and it would always be 5 years off. And then all of a sudden we have a PCP shortage. And now, now we're in it, and there's really no easy fix to getting the PCP shortage fixed. And a lot of the things that they've done to try to fix the PCP shortage in the past haven't worked. In the state of Michigan, there are 3 new med schools compared to when I graduated from med school. Each one of them said their focus was to turn out primary care physicians when they went live. None of them have met that need. Because when push comes to shove, when those med students graduate from med school and they look at what their student debt from med school, which is often $200,000 to $300,000, and then they look at the pay of a primary care physician compared to the pay of a radiologist or an orthopedic surgeon, and it's 3 to 5 times differential. It's not a hard choice for them. They go for the one that's 3 to 5 times higher than primary care that will allow them to pay off that huge debt in a very short period of time. And so, whereas for me in primary care, I make a very good living, don't get me wrong, but I was 50 before I paid off my student debt, and so they're looking at that and they're like, I don't want anything to do with that. And so it's that, unless we change the income equation to make those incomes more equitable between the specialties. And I'm not arguing that primary care physicians are paupers. They're not. I'm arguing that you have to fix the balance between those choices for med students. Otherwise, they're always going to go for the higher paying specialty, and we're not going to have primary care physicians coming into the workforce. And that's how we got into this problem. The second thing I would say is that what we're trying to do to mitigate it is we're trying to understand our value and risk contracts helps, because we can understand what is going on with that population, what are their needs, and how do we put a care team around that physician to help offload the need, and increase capacity for that physician, so they can care for more patients. But to me, it's a shorter term fix. It's not going to solve the longer term problem that we don't have enough primary care physicians. The second place, completely unrelated to physicians in frontline, is as we move into value, we really need to have strong data and analytics, and in particular data engineering, to bring a lot of this data together. And there's a shortage of people and skill sets for data engineering, especially in the healthcare space. And that's a struggle that we run into, and we have to give ourselves a lot of time to find the right person, and in particular finding people who are competent in both clinical EHR data and claims data is almost unheard of. We usually find that we have to hire one or the other and then train up the skill set in the piece that they're missing. And so that's the other place where I have a lot of concerns, because I know we have to build the structure fast, and it's a bottleneck on getting access to the resources, and that's one of the reasons why we look a lot of times to different, consulting firms or to different, outside vendors to help us build things out, because they have that skill set that and we can go quickly.
Well, and you're exactly right, Bob. And so part of the things in the short-term strategy that we can do is, data literacy across the organization. And so that way, when we're asking questions, we're making sure that, one, we're actually asking a question, not just saying, hey, give me this data stat, because that's where you spend more time, especially in a shortage, and it's harder to get that throughput and analytics. So I think a lot of that's there. And then understanding, kind of making sure that we really have that understanding across the board. The teams have also been working on self-service tools. It's not Field of Dreams where you build it, they'll come, but at least for those who have that desire, who have some of that savviness, you now can push that work over to them and then move on to the next cohort to kind of teach and model out. It's not a perfect solution, doesn't solve it all, but it's how you work within the constraints that we have.
Great. When you think about, I mean, a lot of like some of our conversations, and then others that are writing in the space, they talk about sort of the focus on specialties and kind of going from specifically government and Medicare Advantage to taking more risk-based contracts on more risk-based contracts within the specialties. What are some of the dynamics or kind of areas that you've found challenging, or where do you see that going?
So I think a lot of the challenge is the education component. So those specialties, let's pick on CKD and ESRD, and that demo, or it's no longer demo, but it's in full implementation with CMS. Many of those physicians, those specialties are already independent. And so if they're saying, hey, we're interested, that's because they've done homework to understand what am I interested in, what are the terms and conditions, and are likely partnering in their analytics. When we're part of an integrated system, which is exciting, that same level of data literacy and actually understanding the contract terms, it's still a work in progress. So I think that's been a lot of what we've been doing probably in the last 2 years, is actually meeting with the chiefs, the division chiefs, and all the way down, cascading downward, to educate them about what contracts are we currently in? What does this mean? And really educating that it's not just about savings to a health plan, savings back to the patients we serve. Because as costs go up, those costs are directly transferred back to them. And when, we kind of don't partner together in helping control the cost conversation, that means patients forego care. And when patients forego care, those conditions exacerbated, they're more complicated to treat. So how we do that is we get up front. We're still very much in this fee-for-service balance with value. And I think that's a space a lot of organizations are probably working through, especially with the pressure of inflation costs and how to offset some of those spaces. So I think that's another dynamic, especially if you're in an integrated system. If you are external, you might have different places where you can spread costs, but when you're in, part of a system, you don't always have those levers. In terms of what's driving it, when we look across our population, so it's going to be different across those markets. Medicaid is very different, a population near and dear to my heart, but it's very different. When you look at commercial and MA, and even traditional Medicare, so much of this is in the cardiovascular spaces. So it's about how do we get further upstream? And this is the exciting work that Bob and team have kind of been really laying out the seeds for us. How do we get further upstream so they're not crashing into heart failure? They're not crashing into ischemic conditions, and we get further upstream. I'm not saying we're there yet, but that's where we're building the data to go.
And we are building to get there. And one of the keys, we talked about this early on, because we really do need to get upstream and stop the heart attacks that lead to heart failure, stop the strokes, stop these things. But to do that, you have to understand you have to have a big enough population that you can see a statistical improvement, depending on what the percentage is. But then you have to understand, you have to know what your prevalence is, and you have to know what your incidence is for those conditions. And then when you do something, you have to be able to show that your incidence dropped, so that you can then put a cost effectiveness in that. And that's a 3 to 5 year plan to do that. And we're getting there, but most data is not, EHR data is not designed to give you incidence and prevalence. And in fact, a lot of it doesn't even have longitudinal views. When we started, as an example, with our practice, we realized that the data field within our EHR that told us who the primary care physician was not kept historically. It was just a snapshot in time then. And so if I wanted to go back and look at 3 years ago and say, who are all the patients that I had 3 years ago, and then retrospectively trend forward the patients that stayed with me over time, I couldn't. Because if I went back 3 years ago, all I would be getting is who are all the patients who were in our system 3 years ago who have me as a PCP now, not who had me as a PCP then. And those are the things that we like. That's just one piece, but those are the things that we really had to work through and recreate the data models to allow us to track. And it's, these are things that are really techie, weedy things, and managing up and across to explain what we're trying to do. Because quite frankly, most senior leaderships just assume that given how much they've paid for these products, that they do this stuff, and they're quite shocked and appalled when they find out that they don't. So it's a managing up and across and a really a change management thing there to get people to understand. Yes, we have these great tools, but they're not designed where we need for what we need to go to. They were designed for what we were doing 10 years ago. I would also say that when we talk about like cost and the premiums, there's a stat that I remember from in our region where it's over 50% of our population that if they get hit with a unexpected $500 bill, it'll bankrupt them. It'll sink them. They can't handle $500. $500 unexpected cost is not even, if you get sick, that's the minimum thing that you're going to probably get hit with. So we have to get better at hitting the triple aim, really improving health outcomes, making sure that we're creating personalized care that creates an exceptional experience for our patients, and lowering the total cost, because right now we take up way too much of patients' costs and their livelihood in healthcare, and we got to figure out a better way.
Well, and to your point, this is where I think there's two spaces of cost, and we need to understand them both. One is affordability. Affordability is that piece, whether it's premiums, coinsurance, co-pays, deductibles, that's the piece to our patients. And that's so critical. The other piece is understanding then our cost to supply the care. And I think that's critical because you can understand the population, you can identify the areas of improvement. But if we don't understand our cost margins and what it's going to take to get upstream, how that changes, or just some of the things that we're doing in current state and how that has a domino effect, those are opportunities out of the water. And again, this is where partnering with specialties are exciting. I do get a little concerned when we start to piecemeal them out, because ideally what value is supposed to do is bringing us all together, not stratifying about here's how I can win as a PCP and here's how you can win as a nephrologist. It should be about how do we collectively coordinate to manage that patient as a whole.
And there's, that cost to deliver is a big one. And it's again, at these places where I think, a lot of people would be shocked if they understood where healthcare is compared to the rest of our economic industries on their ability to understand cost to deliver. If you look at General Motors and you ask them, what's the cost to build a car? They can give you that in a heartbeat. They wouldn't be able to operate if they couldn't. That is not true in healthcare. When I started 20 years ago, I remember one of my residency attendings getting irate with someone. I'm not going to say who, but because they had dared to say that they should think about cost. And ethically, he was irate, saying, it is not my job to consider cost. My job is to consider what's best for the patient and treat them irrespective of cost. And ethically, at that time, that's what physicians thought. Well, it is your job to think about costs, because if you give something to a patient that bankrupts them and don't consider what other options and talk with them about that in a shared decision-making way, you are doing them a disservice. And so, we have to think about cost because of how expensive we've become. But the other piece of that is because it was ethically considered, you don't talk about that. And because the way that we were paid with Medicare, it was literally, we would just say, okay, here's our fees, and we'll add that we had last year. We'll add 2% to the top of that to adjust for inflation, and that's what we'll get next year. And nobody ever figured out how much does it actually cost to deliver a specific piece of care. And we still struggle with that. We're getting better. We're building cost accounting systems, but that's, again, another relatively new thing in healthcare, which was shocking to me when I first got into healthcare that we didn't have that. And we have to get there if we really want to understand how to lower cost to patients in the long run.
Absolutely. And you both certainly are quite a ways down the path, both as an organization and as individuals in this transition, to risk-bearing contracts and value-based care. There's many across the country, as you well know, that are just sort of starting on that journey. If you could go back to kind of the beginning of that, and what would you say to those that are kind of just starting out or a little bit earlier in the path? Like, what have you learned, or maybe just kind of some quick, just pieces of advice for those that are just embarking here?
Analytics will make or break you. You don't have to have a Corvette, but you need to have a Fusion or a Focus. And so to start, and not understanding, at least at your core, where your utilization trends and patterns are, who is your payer mix, all of those components, you need that to understand, who do I even enter a contract with? What does that contract look like? And then what should my performance goals realistically be? As you progress, you can then layer on all of these exciting tools and ways that we've talked about, but you have to have that investment. And I think that's the other piece too, is that your organization has to understand. And again, there's so many competing factors, right? It's, how do we pay for the direct line clinicians? How do we pay for our sanitation engineers? So data often gets, ooh, do we need it? Yes, you do. And I would argue you need it for managed care as well, because that's how you realistically and reliably report out your potential revenues and expenses. But data at its basic is where it starts.
I would agree with that. I would say, for lessons learned, there's two types of data that you have to focus with, and they have to be intertwined with each other. One is claims, because you have to understand what your total cost of care is and what your utilization is in big areas of where that's coming from. But if you can't connect that to your EHR and clinical data down to a service line or a practice and understand truly what's driving that cost that's actionable, I've seen it over and over again. As a clinician, I've done it over and over again, where payers will give me cost and utilization reports just on claims, and I just kind of shrug. I'm like, I don't know what I'm supposed to do with that, because it's not actionable. It's 30,000 feet up. It has to connect it to the clinical data. And so one is, you need to be able to connect those, gather and aggregate, process, clean up, deduplicate all that data so you can use it. The other piece of it is that you're not going to be able to just go and buy something off the shelf and plug and play with your data. Because if you've seen one healthcare system, even with the same EHR system, you've seen one healthcare system and how they collect their data. Because each of those systems, like sometimes if you've seen one healthcare site within a healthcare system, because sometimes even within an office, the providers collect data slightly different than they do in the other office within the same specialty. Now that's a whole nother problem, and I'm not going to get into there, but you need to be able to understand, how do you collect your data? You need to be able to understand, how are you going to pull that data discreetly so you can capture it, and then connect it to your claims data and make sure that you can define your populations well within those service lines so that you understand them. And then you need to know every site's going to have their own opportunities and their own programs that they're going to set up in those opportunities that they need to report out on. And so if you go and you buy this big suite, or you try to build it so they will come kind of approach, what you find is that most of the reports that you're getting, you're not going to use. What you need is the data underlying it. So it's really critical to be able to see that data, work with, have somebody you can work with that can help you understand your data, build it out the way you need it, and then help you build out the different things that you need within your program. But if it's just a stock, you're buying something like, here's what we do, and here's our experience is that we don't use 90% of the reports, and so we're paying for something that 90% of what they're offering we can't use, and what we really want to get to is the data underneath it. So I think data, when we talk analytics, data and aggregation and normalization and de-identification is critical. Being able to aggregate multiple different sources of data and normalize them is critical. The other piece of it that I would say is that when you go into, you're starting to value, most of the time you're starting in primary care in a lot of places because of the way risk contracts are set. If you go and you try to keep doing fee for service and then do value in the same sites, you basically quarter your primary care physicians using an old English torture mechanism. It feels like you're in two canoes, a foot in two canoes, and they're going in different directions for the providers, because the system, what you need to do to win at value is almost diametrically opposite of what you need to do win at fee for service. And so what we've really found success in is isolating out practices and saying, you are a value practice. These other practices, you are fee for service. Because then you can really focus on changing the culture and the process and your workflows all into a value model versus having people feel like they're trying to do two different things at once, which we tried and we ended up failing. That was one of those painful lessons learned.
And I
Well, you
would say
touched.
too,
Oh, go ahead,
sorry.
please.
Well, with the baseline data, and you were alluding to this, Bob, is that we need both baseline data and then real-time reporting, right? Because
Yeah.
it can't just be a one snapshot. And I think that's often a pain point that happens is that, okay, we tell you that your PMPM is $100 above everyone else when we risk adjust. And so now you need to reduce it. And maybe let's say we can even tell you where. Okay, but you need real-time data then, or close to, and you need to understand up front your leading and lagging indicators. So that way you help kind of play catch up with claims lag. No one likes that lag. No one, even on the payer side, it exists. We can't be upset about that. So how do we find leading indicators? And again, I think this is where that data literacy is so important. The other piece too is finding really great partners in your community that you can try and fail with. Because your first few years, that's what you're going to be doing. Even if a payer has 20 other contracts out there, to Bob's point, you're different. And so your populations look differently. So the tools and how it's designed in the terms should be different. And so we both have to go into it knowing in an open mind that it's okay if we fail a little bit. But as long as we're in this together, and we recognize by year 3, we want to start to see more stabilized progress. And then by 5, it's flowing, and you understand it's iterative. I think that is a really great place to go. Quantity is not your goal here. Quality of the contract is your goal.
Yeah. If I can add one little quick thing there, the thing that's really critical too, and we've found this over and over again, real-time data as much as possible for your leading metrics is key. You can't use claims data because a lot of times you're putting in, like, I'll say you start out like our advanced primary care site. We started an advanced primary care site where we've got these providers starting and they're focusing on high risk patients over the age of 65, and they're trying to improve their outcomes and decrease cost and utilization. So keep them out of the hospital, keep them out of the ED, improve their overall health and well-being. Well, if we're trying to track that, one, we need to know 6 to 7 months in if it's working. If you're using claims data, you might get your first report 4 to 5 months after you start, showing you what happened month 1. The other piece of it is you really have to have really good, most of the industry calls it attribution. You sometimes hear impanelment versus attribution. In our system, we use impanelment to say how we identify patients within our delivery system, tied to a practice or a provider. But attribution that the payer does, what we found when we look at payer attribution down to a site, it only matches about 60% of the time with who's actually being seen at the site. So you need to be able to understand and use who is being managed at that site early on and tie it back to leading metrics, but also tie it back to your claims. Because if you're using attribution, many of these programs, you're hoping for a 3 to 4% differential. Well, 40% of the patients aren't even being touched by your intervention. It's really hard to show a 3 to 4% change. So it's
but
both.
I think that's where attribution still is important, because if we're only touching 60, we're responsible for the whole 100. What is happening with those 40%? Why aren't they coming in? Is it because the claims haven't caught up yet? And maybe they are, we just haven't caught them up. Or is it because they're truly falling through the cracks and they should be intervened? So again, these are all the slices of data that makes it so exciting, and the kind of answers as you're thinking, to your point, about how do you process and prove? You can slice the data in different ways.
And to clarify, we get about a 90% attribution to our PO. It's when we get down to the site that it clears. So it gets very layered, and you have to really understand those things. And to Kristyn's point, that 10% that we don't even know about them. Well, who are they? How do we engage them? How do we make sure that because they're ticking time bombs sometimes. Anyway, I'll stop there.
Yeah, well, and you touched on one of my favorite topics in this, and I think it's one that many overlook, and it's kind of the integrity of the data that's coming in, and the the ways that the variation of different ways that specific topics are represented, right? If many I think maybe oversimplify or overlook the fact that the field office visit just doesn't flow through nice and clean, right? It's an amalgamation of how many different CPT codes, and like how do you represent an A1C test? It could be 7 different ways depending on how it's inserted in that EHR, and so that code value mapping and how you're able to create those logical groupings in a trusted way, right? I mean, it can't happen with every analyst having that list of CPT code definitions on their desk, right, that they're using to apply to their report and then report up, and then the other analyst 2 cubicles down or 2 homes down in the virtual world these days has a different definition, right? And so I think that's where we see a lot of these programs really kind of start to struggle to get to that data trust factor, because they don't either have those centralized definitions, or they're maybe oversimplifying what has to happen in data preparation to make those definitions standard, to make them trusted.
You really, absolutely, and that is a pain point for us, because it's not even like it's like the metric can be defined by the lab in certain ways. Sometimes they use different units to measure some of these metrics, and so then you have to convert them and other things to get them so you're in a standard. But the other piece of it is that depending on which program you're looking at, is it HEDIS, is it MIPS, is it like there's different definitions for the metric. And then there's best practice that our clinicians want to follow for the target, which may be different than all over again. And if we don't really look at all the ways that metric is defined and decide what is our standard, it causes confusion. And we're learning this the hard way, because depending on which metrics used, whether it's HEDIS or MIPS or the standard, it's going to be a different percentage. And then senior leaders are looking at that and they're like, well, why is this percentage different than this percentage? And you start to get mistrust in the data, even though the data is fine. It's just there's different ways to define the metric.
Well, and I think, it starts on how you structure your data, right? Like you've highlighted this beautifully, Rich, about understanding what your end goal is. And that's one of the things that we've been working really hard on, is ensuring that we have all the use cases collected, well documented out. And then that helps build your data literacy, data governance repository, because depending upon the question you ask, and that's I would say the phase that we're in, is how do we help spread data literacy? So that way folks aren't saying, hey, I just need to know an A1C. Well, there's 20 different ways you can pull it, 10 different ways you can define it, and the answer is always going to be different. So how do you ensure that we're providing the right answer for the right question? And I think that's where we're really striving to go. We're making inroads in some places, other places that's still an opportunity. But I think that's really important, and understanding those nuances, not to discourage people, but to ensure that we're communicating and we're keeping that trust and data going. Because if this is valuous, even if you're just talking about HEDIS, dollars and 5-star bonuses, that's still a space that's new. And right away, as soon as you say, hey, your A1Cs are, a little bit higher than your peers, everyone's like, ooh, I don't trust your data. So you have to, and understandably so. So that's why that data integrity is so critical on the front end, and ensuring even where there are limitations, calling those out. Don't pretend data is perfect. It's not supposed to be. It's not static. But what do we know, and how is that okay, those limitations?
Absolutely. And as so we're with the goal here, obviously, is continuing to foster this collaborative dialogue. One thing that's interesting, I mean, where do you both go for kind of top sources of intelligence, right? Whether it's books, podcasts, groups, collaboratives, maybe some ideas, just those shared that you can share.
So there's a lot of different sources I go to. There's a user group on our EHR that I go to talk to people there. There's AHIMA, I go there and talk to some people there. There's Population Health Management Journal, which has some really good stuff that comes out related to it. I like Health Affairs. There's some things that help me with that. There's the book that's in my corner here, and I didn't forget the books right now. But there's this Pop Health Analytics book that I find is my favorite reference book for analytics. I go to that quite a bit, and it's a lot of times it's, I still just use the classic Googling to find, things I'm looking for when it comes to certain things, and going to PubHub and looking there for literature and journals. So it's a combination of those kind of things that I look at. But networking is another one I do. Is looking to other organizations that have done this, looking to other key figures and reaching out to them and just talking and trying to understand, okay, what's your journey been? What have you learned? What's the, similar to the conversation we just had today, where it's like, okay, here's what we're doing, but it's what are you doing, and how do we learn together? Because we're all going, this is really early in the journey for value, and we're all going through a lot of these hurt points. There's only a few places that really have done this a long time, like Kaiser. Okay, one. Name me another that's done it like they have done it as long as they've done it. The rest of us are like, just starting on a journey, and we're not a closed system like that. So how do we navigate it?
Yeah, so I completely agree. So my background's political science, and coming from the government space, I read the regs. I actually read all 500 pages, 400 pages, whatever they are. The devil's in the details. And part of that's not just when they're proposed rules and they change. Understanding to try to read the tea leaves of where are we going? What is that push? What does that look like? And that doesn't always mean knee-jerk reaction. We have to do that. But just understanding, if we're not, what is the risk? And is that, I'll make sure we're okay with that. So I'm a good old fashioned regs girl. I love modern healthcare as a skinny to just say, okay, this is where we go. Becker's is another one that I enjoy. I read a lot of state news as well to understand what's happening in our state, even, in broader spaces across the economy. And what does that mean then for, again, the health of our patients? Same book, got it right here. It's my favorite. I have it earmarked, flagged, and I've probably read it cover to cover at least twice, with some sections multiple times. So the Population Health Analytics book, love that book because it's a nice, easy, digestible way for references, especially as you're thinking about use cases. I really enjoy that piece. And then, as Bob said, phone a friend. There's all sorts of analytic conferences out there. You can pick you find your tribe. But when you go, make the most of that. Make those connections so you can ask, hey, I see you're doing this. And there's a lot of great things that, we've seen presented at those conferences where we take it back and it might look a little differently. And that's okay. But how do we learn? So I think that's probably, where I kind of go the most.
Amazing. And oh yeah, please.
When it comes to SDOH, you were talking about that. And when it comes to SDOH and analytics, there's the Gravity Project. And I have been going there quite a bit in their website and really trying to understand what they're doing, because they are starting to set some really good framework and getting a lot of it buy-in from large health corporations, payers, and vendors of coming up with the standards of how do we collect this data so we can transmit it across different entities, in particular at the level of a healthcare system with community organizations, so that we're all using the same standard and the same domains, so we can start to really understand populations and be speaking the same language. So that's another place I go to try to understand what are other people focusing on in that area.
Amazing. And we'll drop some of these links in the show notes. And we certainly have the Population Health Analytics book in common, as we've discussed. All of our product managers and I have read this from cover to cover as well. It's a phenomenal resource. Well, thank you both so much, Kristyn, Dr. Jarve. This was an amazing dialogue. I think it's going to be, it's just a wealth of knowledge and just a really, really great rapport that you both have, and I always enjoy our time together. So thank you again.
Thank you. This was a lot of fun. I really appreciate it.
Thank you so much.